Hi, welcome to class number 2 of Medical Assistant Module 2. Today we're going to talk about the vital signs and the anthropometric measurements. This is what we are going to do as a medical assistant. This is our physical examination for the patient visit on that day, okay? We're going to start talking about what is a vital signs and what is anthropometric measurements. Vital signs, like the word say, is signs of life, signs of that patient it's alive. It doesn't mean that it's good, it's bad, or it's normal. It just means that the patient is alive. And these 4 measurements are going to be temperature, pulse, respiration, and blood pressure. So we have 4 vital signs. But when we evaluate the patient, we're also going to evaluate the anthropometric measurements. And this is because this information is going to help the doctor to finalize either a diagnosis or a treatment for the patient. Some of the medications used in pediatrics or geriatric patients, elder patients, are based on the height and the weight. That's why it's so important. And we include it in the vital signs measures. But the vital signs are 4: temperature, pulse, respiration, and blood pressure. Anthropometric measurements is going to include height and weight. And in the pediatrics, in the infant, in the child, we're going to use the head circumference. We're going to measure the head around of the kids. That's going to give us information about growth. These measurements are going to help us to evaluate any health problem that the patient has. In combination, vital signs and body measurements is going to give us an idea of what can be happening to the patient and can help to complement the diagnosis of the patient. The vital signs are going to provide us the patient overall condition. This is going to confirm if the patient said that they're feeling palpitations, heart rate, or pulse is going to confirm if this patient is having indeed any acceleration on the pulse or the heart rate, and that confirms the palpitations. If the patient is coming because he's saying that he has fever, then we are going to take the vital signs, and the response of the body to the fever is going to be the increase on the heart rate. So we can prove that, okay? That's measurements, that's our objective. The vital signs has to be taken as a baseline if it's the first time that we see the patient in the office, but we will take it in every single visit. It doesn't matter if the patient came a week ago or 2 days ago. Every time that the patient comes to the clinic, we should be measuring these vital signs, and as well, height and weight. Let's think in a patient that has a condition that is accumulating fluid in the legs. They're having swelling. If they come yesterday and they weigh 100 pounds, but today they show up and they weigh 120, that means that accumulation or the swelling on the legs has increased significantly in 24 hours. So that's why it's so important for us to do it every single visit. It doesn't matter how close it is to each visit. The information that we get from here, this is a personal and private information. So this is protected by HIPAA. So you have to be really careful the way that you are going to update your provider with these vital signs. Either you communicate directly with the doctor in a private way, but you cannot be telling the vital signs in the middle of the hallway because it is a personal information and is protected by HIPAA. One of the measurements that is not a vital sign, but we have been now seen being taken often and as a part of the vital signs is the pulse oximeter or the saturation of oxygen. This starts since the pandemic with COVID as a part of the measurements that we have because it's given us the complementation of how good the respiration or how effective the respiration is. So we are going to include, and we are going to look for these vital signs. The heart rate is going to be the normal from 60 to 100 beats per minute. Beats per minute. So that means that you have to count how many times you feel the pulse in the patient for a period of a minute, okay? This can be abnormal. The normality, 60 to 100. If it's less than 60, we are going to call it bradycardia. If it's above 100, then we're going to name it tachycardia. And this is terminology, so let's pay attention to it. Brady means less or down. Cardia is going to be referred to the beats of the heart. Tachy means above, up. And cardia means the palpitations are related to the heart. So tachy is more than 100, Brady is less than 60. The blood pressure is going to be 120/80. And this is the information that we get from the American Heart Association. But to make sure, you have to evaluate the patient as the patient, okay? Not every patient is going to have 120/80 as a normal. For example, my blood pressure normally goes between 110 to 116 over 70 and 75. That is my normal. If my blood pressure goes above 120 and 180, I am starting feeling bad. So just because it's 120/80 doesn't mean that that could be normal. We have to see the patient as a whole. For learning purposes, the normal blood pressure based on the American Heart Association is 120/80. And from that measurement, we are going to go and evaluate the abnormal and the normal. The abnormal then is going to be hypotension. Hypo means low, tension means blood pressure. If it's less than 90/60, then it's considered hypotension. If it's above 130/90, then it's going to be hypertension. Hyper means up, tension, blood pressure. Respirations. The normal respirations go from 12 to 20. In this chart, it says 10, but the normal goes from 12 to 20. And this chart is referred to a standard adult. The abnormal of the respiration then is going to be less than 12, is going to be hypoventilation. Hypo means low. Ventilation is the movement in the respiration. More than 20 is going to be hyperventilation. Hyper means up. Ventilation is the movement in the respiration. The temperature is going to be normal, 97.8 to 100.4. And this is the limits of normality. If it's less than 97.8, then we consider that the temperature is low. So it's hypothermia. Hypo means low, thermia, temperature. If it's above 100.4, then we are going to start talking about the states of hyperthermia, meaning the temperature goes up. But we will consider this as a fever or febrile temperature. We talk about the saturation of oxygen as being included part of the vital signs, even if it's not telling us that the patient is alive. It's just telling us how effective is the respiration. So the normal is going to go from 95 to 100. Less than 95 is hypoxemia. Hypo means less. Oxemia means going to be oxygen. When you evaluate the patient, you have to take into account the limits of normality, but you also have to look at patient. You have to see the patient as a whole. Like I was putting myself as an example. My blood pressure normally goes between 110 over 116 over 70 over 75. If I am presenting to the clinic just for a checkup, and they take my blood pressure and they say 110/70, and they ask me, do you feel dizzy? Do you feel lightheaded? And I'll say no, then that means that my blood pressure is normal. But if I will have the diagnosis of hypertension and I'm taking 2 or 3 medications for blood pressure, I know as a medical assistant that this patient, his blood pressure probably is going to be above 130/90 because this patient has the diagnosis of hypertension. If we take this blood pressure and we see that the patient is 110/70 or over 60, and the patient starts saying that feeling dizzy, lightheaded, or have blurred vision, then we have to worry because we have made the blood pressure goes low and the patient, it is indeed in a state of hypotension, okay? With the age, the vital signs might change the range. And like I say, this is range of normalities. It doesn't have to be exactly like it is, but it's a range of normality that we will evaluate. In patients from 12 years above, adults, and probably we're going to include the elderly patients, blood pressure goes systolic from 110 over to 130, over 65 and 80. So then you can see now that I am in the normal range. It doesn't mean that I'm a hypotensive patient. The pulse is going to be from 60 to 100, and the respirations go from 12 to 20. Patients from 6 years to 12 years, systolic blood pressure is going to go from 100 to 120 over to 60/75. The pulse is going to from 60 to 100, and the respiration is going to be from 16 to 22. The youngest the patient, the more increased respirations and more increased pulse that you will see. From 3 to 6 years, blood pressure is going to go from 95 to 110 for systolic and 60 to 75 for diastolic. The pulse go from 70 to 120, and the respirations go from 20 to 24. Remember, the younger the patient, the higher the respirations and the pulse limits are going to go. And the one from 3 years old, systolic blood pressure goes from 90 to 105 over 55/70 on diastolic. And the pulse go from 80 to 150 and respirations from 22 to 30. We have to take care and count OSHA. OSHA is that facility that is going to give us the guidelines of how we have to protect ourselves in our work environment. We work with patients that we have to assume that they are sick until we can prove that they are not sick. So when we take vital signs, because we are going to be in contact with that patient, we have to take care of ourselves. So evaluate the patient. If this patient is having any respiratory symptoms like a flu, sneezing, coughing, or having runny nose, then let's protect ourselves and we can use mask, gloves, and why not some goggles. If the patient has any exposure of fluids, blood, any wound open, or anything that can expose us to the body fluids of the patient, we're going to use gloves. The blood pressure is the force at which the blood is going to be pumped against the walls of the arteries. That's what is called blood pressure, artery blood pressure. The blood pressure in the arteries, remember, the arteries has a middle inner part that is muscle. And that muscle is going to make them contractile. So the arteries are going to be resembling the movement of the heart. Pum, tap, pum, tap. Systole, diastole, systole, diastole. Okay? Contraction, relaxation, contraction, relaxation. Pum, tap, pum, tap. So the arteries are going to be reflecting that contraction and relaxation of the chambers of the heart, allowing the blood being pumped and pushing against the wall of these arteries. To make sure that we can get the pressure in the arteries, we are going to go and look for the pulse of the arteries. And usually we take the blood pressure in the arm. So we are going to go and look for the brachial artery. How we know how to identify the brachial artery? Brachial artery is going to be in the inner side of the arm, and it's going to be aligned with the pinky. So touch your pinky, go all the way in the inner part, and when you get to the antecubital fossa, you are going to look and feel the pulse of that artery that is resembling the heart pumping. We are going to put a sphygmomanometer that we're going to look in a few minutes, and we are going to look for two pressures. Number one is going to be the systolic. Systole means contraction. This is going to be the measure of that pressure that the left ventricle is doing to send the blood to the rest of the body. And then we're going to look for the diastolic pressure. Diastolic means relaxation. So this is going to measure the pressure when the heart relaxes. So the heart contracts, sends the blood outside from the left ventricle to the arteries and the rest of the body. So these arteries are going to be doing the same thing that the heart is doing. Contracting, receiving the blood, contracting to be pushing it, contracting to be pushing. That is what we are measuring in the systolic. For this artery to be able to receive more blood, it has to relax. And that is when we are going to measure the diastolic, okay? So right here we have the composition of the artery. This part right here is the muscle. This is what is allowing the artery to be contracted and to contract to keep pushing the blood to go to the other arteries, but at the same time relaxing to allow the flow of coming in that part of the artery. With diseases like blood pressure, high blood pressure, hypertension, or pre-hypertension, the look of the arteries can change, okay? In the inside of the arteries, the space between the walls is what is going to give us a normal blood pressure. If we have diseases like high cholesterol, hypertriglycerides, this is going to create this part or this arteriosclerosis, which is fat tissue in the inside part of the arteries, and start closing it up. The more close that this canal is, the highest that the blood pressure will be, okay? So when we take a blood pressure and the patient has high blood pressure, one of the first reasons why this patient have high blood pressure is the presence of high cholesterol or fat tissue in the inside of the arteries. We say that the normal blood pressure is 120/80. And we are measuring two pressures, systolic and diastolic. The systolic blood pressure is the pressure of the contraction of the left ventricle. And this is going to be the first number. The diastolic is going to be the pressure when the heart rests and when the arteries are resting, when they relax to allow more blood to get in there. And this is going to be the second number that we obtain. So in this case, 120/80, that means that the pressure for contraction is 120, contraction. And the pressure for relaxation is 80. okay? The American Heart Association is going to give a classification of hypertension based on the normal numbers that they give as 120/80. We have to evaluate the patient, okay? So it doesn't matter that if it's 118/78, that's hypotension. It's in the normal based on what we see in the patient. If the patient presents symptoms and we know that this patient is hypertensive, then it's hypotension, okay? Or we can say this patient normally has hypotension or low pressure. So the normal, based on the American Heart Association, is 120 or less for systolic and 80 or less for diastolic. We can have patients with elevated blood pressure, and this is going to be 120 to 129 for systolic, and 80 and less than 80 for diastolic, like the highest 70s to 80s. Then we're going to enter in the hypertensive stage. And the American Heart Association say that there's going to be 3 stages of hypertension. Stage 1 of hypertension is going to be levels of 130 to 139 for systolic and from 80 to 89 for diastolic. Make sure that this is something constant. If it's the first time that you see these numbers in this patient, and he usually is 120/76 or in that range, if this is the first time, you have to evaluate what happened with this patient. Has this patient been feeling bad? Is this patient presenting any symptom, headaches, or feeling blurred vision, or feeling dizzy, lightheaded, chest pain, anything of that that's going to give us the idea that yes, this patient is on hypertension stage 1. The other thing that we have to take in account is how soon do we take the blood pressure when we take the patient in the room, okay? It's not the same that you, young medical assistant, walk in the hallway, normally getting there, and you probably not going to have an affectation, but you're bringing a patient walking in a long hallway that is 450 pounds, heavy, morbid obese, and that small exercise is going to increase heart rate, blood pressure, respirations. So you have to make sure the moment of when you are taking the blood pressure. Stage 2 for high blood pressure is going to be 140 and higher of 140 for systolic, and 90 and higher for diastolic. And the stage 3 is going to be called hypertensive crisis. These patients are going to have a blood pressure above 180 for systolic and above or higher than 120 for diastolic. These patients, if you get this blood pressure, we are going to recheck one more time. And if the blood pressure keeps being so high, this patient becomes in priority and an emergency. This patient probably is going to be sent to the ER. What are the symptoms that we can look in the blood pressure abnormalities? Low blood pressure or hypotension, patients can present with dizziness and lightheaded. Patients can faint or present syncopes. This is a short period of fainting or syncope. The patients are going to have or complain about blurry vision. Patients can start feeling thirsty because they dehydrated. Patients feel fatigue or complain about the fatigue. And you're going to see that this patient start breathing a little bit faster and superficial, shallow. When the patient presents high blood pressure, symptoms are really similar, But we have to pay attention to, number one, difficulty breathing. This patient is going to have a rapid respirations, but you're going to notice the difficulty. Patients are going to try to get more oxygen, okay? Breathing more with more effort. Patients can complain of chest pain. The pulse is going to be irregular because the heart is in distress. If you send them to do a blood test, urine test, they're going to have blood in the urine. And the problems with the vision is going to include the blurry vision, but also the patient is going to say that they are losing the peripheral vision. So they are going to feel like they're looking in a tunnel. And fatigue and confusion is also a sign of high blood pressure. What can affect the blood pressure then? When we measure the blood pressure, we have to take into account that the information that we're getting from the internal part of the body is the cardiac output, how that muscle is working, how good it's pumping and contracting, but also relaxing. A heart that is not relaxing completely is not being able to full or to fill complete that chamber. So the blood, when they contract, is not going to be good or enough to get into the arteries. The blood volume, vasoconstriction, and viscosity. A patient with high cholesterol, the blood is going to be a little bit more thicker and it's hard to move. You can hear about some terms like benign hypertension and malignant hypertension. Hypertension is bad no matter what. But we consider a benign hypertension when only the patient is presenting elevation on the blood pressure without making any damage in the outside or the other systems of the body. When the patient starts presenting conditions that affect the main organs, meaning brain, kidney, lungs, then that hypertension is malignant because it's making the rest of the organs to fail. Hypotension, like we say, is not all the time, meaning a chronic problem, okay? There's patients that are really healthy. They run marathons, they're fit, they eat good, they don't eat sugars, they do really good about taking care of themselves, and they can be hypotensive. And it doesn't mean that they're sick. It just means that their body is working so properly and their metabolism doesn't require that much pressure to get the oxygens to the rest of the body. But in the case that there's severe hypotension or when the hypotension gets significant in clinic is when we are looking or is part of sign of shock. For example, a patient that is really sick with high fever and is hypotension, this patient is probably getting in a septic shock, meaning that the infection is all over the body. Heart failure, patients with hypotension, chest pain, irregular heartbeat, difficulty breathing, we have to think that the heart is failing, okay? Patient with severe burns or being in an accident, that they have excessive bleeding, patients that have, for example, a car accident and we don't see blood, but they complain of abdominal pain and they are hypotensive, we have to think that they have an internal bleeding, okay? Patients with hypotension that have been in the heat for a long time, we have to think that this is a severe dehydration. To take the blood pressure, we're going to use instruments. The main one is the sphygmomanometer. This is the equipment that is going to be around the arm of the patient, okay? This is the sphygmomanometer, okay? If you see, it has a strap that is going to be around the patient. And mostly is going to show, and it say left arm with an arrow and right arm with an arrow. Depends on what arm do you use to take it. That is the arrow is going to be indicating you where you feel the brachial artery or any artery that you will use. There's going to be a pressure ball. This is what is going to allow us to inflate the device, okay? This is the pressure ball. And my recommendation for you, of course, you're going to find the best way for you to work it out. But my recommendation is, if you're right-handed, you sustain the ball like this, and you will know that when you turn the ball to you is closing up, okay? And when you turn it toward the patient, is opening the ball, okay? The other part of the sphygmomanometer is the actual manometer that is going to look kind of like a clock, okay? If you see, it's going to have the measurements, and it's going to be, it's going to have the digits from 20, every 20, 40, 60, 80, 100, and in between, there's going to be lines. Each of those lines is going to correspond to 2. So between 20 and 40, the middle one is going to be 30, and between 20 and 30, each of the small lines is going to be 2. So 22, 24, 26, 28, and then 30. So when you're using manual one, you cannot say that the blood pressure is 125/75 because the measurement in here, it's on every 2, okay? There's different types of sphygmomanometers, okay? Now we are going to learn how to use the aneroid. The aneroid is the manual sphygmomanometer. But we have digitals, and in most of the clinics now, they have digital ones, but you have to learn how to do it manually, okay? Over here, you have a mercury sphygmomanometer. This is really old-fashioned way. You're probably not gonna see this, but instead of having a manometer, you will have the measurements with mercury. So the elevation is going to be looking at mercury going up and then measure it going down. So these aneroid sphygmomanometers, the small or the circular gauge register pressure that we have, each line, we say it's 2, and it's the most accurate way to take the blood pressure because we are going to educate our ears to listen, okay? Any electronic or digital sphygmomanometers is going to provide the blood pressure, and you don't need the stethoscope, so that's why it's so easy to use. And it's kind of better for us because we don't have to be so close to the patient and we can protect ourselves, okay? But it does require more maintenance for these, and it has to be calibrated probably every 3 to 6 months. When we use aneroid sphygmomanometers, we also have to get the stethoscope. The stethoscope is going to have an earpiece, the tubing, and the chest piece. The chest piece is what we're going to use to put it close to the arm of the patient when we identify the artery so we can get any sound from here. And the earpiece is what we are going to put in our ears. When you see the stethoscopes, usually are like this. Our ear canal is going to the front in the diagonal. So make sure that you move your earpieces to the front to look like this. You see, to the front. And then you're easily going to put it on so you can make sure that your ear canal is open and you're going to have a good listening of those noises that we're looking in the artery. Some of the stethoscopes, like you see here, it has a bell that is rotatory. So you have to make sure that the piece that you're going to put in the arm of the patient is the one that is open so you can hear correctly. what are we gonna do? How we're going to measure the blood pressure? We are going to first place the cuff in the arm of the patient. We have to make sure that we select the artery. You can touch, you can look for the artery. The artery is in the antecubital fossa and is aligned with the pinky, okay? In the inner part of the arm. So if you're looking for the left arm, you're going to see the inner part and you're going to look in that fossa. You're going to place your index and your middle finger looking for palpitation or for that bouncing movement, okay? Contraction, pum, 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 okay? That's what you're going to be looking for. Once you make the identification, then you're going to make sure that you can put the sphygmomanometer in the patient. Remember that it has lines, that it has arrows in there telling you where you're doing. I'm doing the left arm, so I'm gonna make sure that the left arrow, it's aligned where I touch that artery, a little bit above that, okay? Then you're going to put it around. And you have to make sure that you allow 2 fingers to go in easily, okay? Because there is where you're going to put the stethoscope. So the stethoscope is going to be where that artery was filled and where this sign by that arrow, you're gonna put it in there and you're gonna hold it like this with your index and your middle, put it inside, and you're going to make a little bit of pressure against the arm so you can secure that the noise that you will hear is the noise from the arm. Then we're going to inflate the valve. Remember, if you're right-handed, then moving it to you is going to be closing, and move it to the patient is going to be opening. So we're going to pretend that this is the patient. Okay. We're going to put the stethoscope in there. Okay. Put it like this. And then we are going to move. Okay. For that, we're going to start using the manometer. Okay. We are going to you, it's closed. So we move it until it's completely closed. And then we're going to inflate to 180 to 200, okay? Right there is going to stop. It's not going to move. Patient is going to feel pressure. And then we're going to open, turn the patient slowly. You will see the needle starting moving down. Okay? That's what we're going to look. But what are we going to look? What are we looking for? We are looking, or we are expecting to hear the cutoff sounds. Cutoff sounds is what is going to give us a systolic pressure and a diastolic pressure. These cutoff sounds have 5 phases. Number 1 is the first tapping sound that is going to represent the systolic, okay? The first noise is like, it's really like explosion. It's the first hard noise that we hear, okay? Second phase is going to be the swishing sound that is going to become softer. So first is going to be, and then phase 3 is the resumption or a crisp tapping sound. That noise is going to become softer and crispler. Phase 4, that sound sounds to a muffle. It's going to be sounds a little bit far, like. And the phase number 5 is going to be that sounds disappearing. So that loud sounds that you hear, and that is going to be the diastolic pressure. So the first number is going to be 110 I'm sorry, the number that you hear first, where you hear the noise, and the last number is going to be the last sounds that you hear. I'm going to put you a video so you can hear and you can pay attention.
As you can tell, I was not created by GoDaddy.
Sorry about that. I want you to pay attention and you're going to look the measurements, okay? You're going to go and look the manometer and looking for the needle. The needle is going to be moving and it's going to indicate the number. So you are going to look the manometer for the number, but you're also going to pay attention where you hear the first number and when you hear the last number. Okay, you ready?
Hey everyone, let's test your knowledge on taking a manual blood pressure. So what I want you to do is I want you to look at this blood pressure gauge and I want you to listen for those systolic and diastolic sounds.
Okay, so if you pay attention, the first sounds, it was here, over here. So it's 100, 102, 104, 106, 108, 110. The last we hear, it was right here. So this is 60, 62, 64, 66, 68, 70. So that means that the blood pressure is first sound, 110, last sound, 70. Blood pressure is 110 over 70.
Okay, so what did you get for the patient's blood pressure? Did you get 110 over 70? Because that is what it was. Now remember, whenever you're listening for those blood pressure sounds, that first sound you hear is the systolic number, which is that top number of the blood pressure reading. And in our case, it was 110. And at that point, when that sound stops, it's the diastolic number, that bottom number. And in this case, it was 70. Hey,
Okay. So that's what we are going to look. We're going to look the sounds, and the first one is going to be that tapping explosion kind of sound, like, and the last one is going to be that slow down and then disappearing of the noise, like, and then nothing. That was the last one. Okay, so that's your last number. To take the blood pressure, we have to consider the outside factors that can alter this blood pressure. Number one is this post-exercise. Do we make the patient walk too much? Is the patient running late and he was running and we just came to talk to him when he was running from the parking lot? Any ambulatory disabilities. For us, probably it's just like a few steps, but if we have a person that is walking with a walker, a lot of difficulty, that is extra exercise. So that's going to make the blood pressure goes up. If this patient is obese, for example, that patient that we talked 450 pounds, for us it's a few steps. For this patient, probably is going to be extra effort of his physical capacities. Patients that we know that they have high blood pressure, that they have hypertension, and they are on treatment, we know that for them will be normal to be in that range of knowing as an elevated blood pressure or probably hypertension stage 1. What is important? To evaluate that this patient is under medication. Other things that we have to evaluate is anxiety and stress. Being in the clinic and feeling sick is already stress or feeling anxious of what's going on with you. So we have to make sure how the patient is acting. We have to avoid measurements in an arm that has any contraindication. Number one, any injury or any blocked artery that is present. Patients that we know that they have a clot previously in that arm, we're going to use contralateral. patients with history of mastectomies on that side, especially if they have removed lymph nodes. These patients that have this history of mastectomies, that they have removed the breast, they already know that they cannot allow you to put the blood pressure cuff in there. So they will let you know. Patients with implant devices under the skin, for example, patients that are under dialysis, that they have a fistula in there to perform the dialysis, you should not do it in that arm. Patients that are in the hospital with the IVs, we should avoid to do it in that side. Let's try to do the opposite one, okay? And of course, we have to make sure that the proper cuff side is applied to the patients. Patients that are obese, we're not going to use the smallest. Patients that are really thin, we're not going to use a normal one. We're going to have to adapt. And in most of the clinics, you're going to have all the sizes for the blood pressure cuff. In children's, usually we take one blood pressure as a baseline, and then we don't take it in every visit. We can skip a few visits and then we check in the next one, okay? We have to take the blood pressure before any other procedure is done. For example, this patient is going to have blood work, this little kid, so then we take the blood pressure first and then we do the other procedures, because if not, we're gonna make the blood pressure goes high. With the kids, we can use a method to take the blood pressure that is a palpatory method. And with this, what we are going to do is we are going to put the blood pressure cuff, we identify the vein, the artery, and we're going to start feeling the rate, the heart rate, the palpitation. We inflate, and when we feel that it stopped, then we stop inflating and we start deflating. When we feel the pulse again, that's our first one, that is systolic. And when we feel that the pulse start getting weaker, that's our last number. To make sure that the blood pressure is a good blood pressure, we have to make sure that the position of the patient is a good position. We're going to allow the patient to rest for 3 to 5 minutes after we walk them and we put them in the room. We're going to ask them to put the feet flat on the floor, okay? Not crossing the leg or not just sitting on the leg. It's both feet, the feet flat in the floor. The best position is having a place where the patient can support the arm aligned to the heart. But if you don't have a place like a table or the bed, if we don't have that, you're not going to have the patient holding it, because that is going to increase the pressure of the patient trying to maintain their arm up. So we're going to ask them to keep it close to the chest, close to the abdomen, or simply relaxing next to them, okay? The patient has to be sitting in a chair, and the back has to be laying to the backrest. The patient has to feel comfortable and relaxed, okay? What is going to happen if the patient doesn't have an arm, or the patient cannot take in any of the arms? We can take the blood pressure in the wrist area, and we're going to use the radial artery. We can use the legs. We can use the popliteal artery that is located in the back of the knee, or we can use the feet above the ankle. And that is going to use the posterior tibial artery or the dorsal pedis on top of the feet, okay? To start talking about the rest of the vital signs, we're going to talk about pulse, respiration. Pulse and respiration are vital signs that are linked to each other. And this means pulse is going to evaluate the circulation, respiration works the work of the lungs in the respiration. And these are going to be linked, meaning that if the respirations increase, heart rate is going to increase. If the heart rate increase, the respirations increase. If the respirations decrease, blood pressure, heart rate is going to decrease. If the heart rate decrease, the respirations is going to decrease. So they're linked to each other. They act the same way. The pulse or the heart rate is how many heartbeats do you feel in a period of a minute? Respiration is the number of times that the patient breathes in a minute. The ratio of the pulse and respiration is 4 pulse by 1 respiration, 4 by 1. So every time that the heart beats 4 times, there's going to be 1 respiration. That's the normal. And 1 breath or 1 respiration is going to be 1 inhalation and 1 exhalation. The heart rate or the pulse then is going to be from normal, from 60 to 100. How many seconds are in a minute? 60. 60 seconds, it's equal to 1 minute. 30 seconds, it's equal half minute. And 15 seconds, it's equal to a quarter of a minute. So to take the heart rate or to take the pulse, you're going to locate the artery where you're taking the blood pressure, the heart rate. In this case, the most common place to take the heart rate is the radial artery. The radial artery, it's aligned with the thumb. What are we doing? We're going to locate the thumb, follow, and when we get to the wrist, you're going to feel right here, there's like a little space, like a little fossa in there. If you make pressure in there, you're going to start to feel the pulse. That means that you are getting or you're touching the radial artery. So we are going to count how many times we feel in our fingers that pulse in 1 minute. You can do it for the whole minute, or you can use 30 seconds, half minute. How many times I feel it in half minute? So let's say that I feel 42 in 30 seconds because the heart rate is measured in 1 minute. That means that those 42, I'm going to multiply by 2. So 42 by 2 is 84. Okay, so my heart rate is 84 per minute. If you want to use the technique for 15 seconds, that means that you're going to multiply by 4. So let's say that you feel 20 in 15 seconds. 20 pulse in 15 seconds. 20 multiplied by 4, it's 80. So that means that my heart rate is going to be 80 per minute. So you can use the whole minute, stay the whole minute in the wrist of the patient, feeling how many pulses do you feel, or you can use half minute. And if you use half minute, you're going to use the number of pulse that you feel multiplied by 2. And that is going to give you the beats per minute. Or you can use the 15-second one, meaning the number of pulse that you feel multiplied by 4, and that is going to give you the beats per minute. The normal heart rate goes from 60 to 100 beats per minute. Anything above 60 and anything below 60 and anything above 100 is going to be abnormal. And those abnormalities are going to be above 100, tachycardia, and below 60, bradycardia. So your homework for today is going to be taking pulses to everybody at home, okay? Go and make sure that you're good making the identification of where that radial artery is. What if we cannot use the radial artery, or we cannot feel the radial artery. There's other places. If you feel in your temporal area, you will find the temporal artery. Then if you go to the neck, you're going to feel the carotid artery. This carotid artery, that's the second place most commonly used to feel the heart rate or the pulse. The brachial artery. The brachial artery is the one that we use for the blood pressure. It's really exposed, really easy to look, so that's going to be our third place to look for the pulse. We can feel a femoral artery that is going to be in our groin area, in your inguinal canal. The popliteal artery that is going to be in the back of the knee. The posterior tibial artery that is in the inner side of our feet. And the dorsal pedis that is in the doors of the feet. Always to measure, use your index and your middle finger. We never look for pulse with our thumb because the radial artery is too close to it, to the thumb. So it's giving our own pulse, okay? So we can confuse our own pulse with the pulse of the patient. So we use the index and the middle finger. The carotid artery is going to be located in the neck. You can select or you can look for the sternocleidomastoideus muscle, which is that line or that feeling of a strain in your neck when you turn to the opposite side. And you're going to make a triangle with your jaw. In the middle of that triangle right here, you're going to locate your carotid pulse, okay? Brachial artery, we already know that it is palpated in the antecubital space or antecubital fossa in the inner side of the arm. So it doesn't matter what arm, you can align it to the pinky in the inner part, the closest to the medial line, the inner that it is, so the inner part is right here. Antecubital fossa is above the elbow, so you're going to locate it right here. And that's the brachial. When you're looking for the pulse, you're not just looking or feeling the pulse. You're not just going to go and count how many times you feel it. You're also going to go and notice any irregularity on the pulse. Because remember, the pulse is the contraction and relaxation of the artery, but it's also reflecting the contraction and the relaxation of the heart. So if you have a irregular heartbeat, irregular pulse, that means that your heart is irregularly pumping the blood. So that means that this patient can have a cardiac issue going on. In case that you make an identification, if you use the 30 seconds or the 15 seconds and then you multiply by 2 or by 4, if you feel an irregular pulse, let's say that is not poop, 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 poop. It's irregular. It's not constant, like boom, 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 boom. If you feel the irregularity, then you have to make sure that you count again and you count the whole minute so you can identify that you really are feeling irregulation on the pulse. When we talk about vital signs, we say that we are going to include the saturation of oxygen. But this is not a really vital sign, but it's related to the respiration because it's telling us how effective the respiration and the oxygenation is getting into those small vessels, okay? So saturation of oxygen, we are going to get it with the pulse oximeter unit, okay? This is an electronic device that we are going to put in the finger of the patient. It could be in the blood pressure machine included in there. If not, we're going to have, I'm pretty sure everybody get one when COVID started, right? And if you see, it's going to give us always the percentage of the oxygen, but it's also going to give us a heart rate. okay? And this is the relationship that is in between the respiration and the respiration and heart rate, okay? The normal, we say that is 95 to 100. Like, you know, the other vital signs, we have to relate how the patient looks, okay? Because the patient can be 92%, and we have to report these as the low levels. But maybe the patient looks normal. Maybe the patient is a smoker. Maybe they're vaping, but the patient looks okay. But it just means that the amount of oxygen that is getting is not normal. But it doesn't mean that the patient is in a bad condition. Now, if you see a patient with 76 of percentage of oxygen in the pulse ox, and the patient is having a really deep, heavy breathing, like patient is in distress. So that means that this patient is not having a normal vital signs and is reflecting with that percentage being so low. So the respiration is regulated by the nervous system, okay? And what part of the brain or the nervous system is regulating this is the medulla oblongata, okay? This is who regulates the respirations. And it's important to know because in some cases, when there's an affectation of the nervous system, accidents, strokes, or anything that happened in the brain can affect the respiration, okay? So to make sure that we count, we are not going to tell the patients, let me count your respirations, because that is going to make the patient aware, and the patient can increase the respiration or decrease the respiration because he is aware of what you're doing. We are going to use the same technique. We are going to count a minute, and we're going to count how many times the patient is breathing, or we can use 30 seconds and multiply it by 2, or use 15 seconds and multiply it by 4, okay? So we can go the whole second, that is 1 minute, or we can use 30 seconds, that is half a minute, and we're going to multiply by 2, and that is going to give us the breath or respirations per minute. I'm going to use the R so you don't get confused. Respirations per minute. Or we can use this 15 seconds. We're going to count how many times we see the patient's breathing. This is a quarter of a minute. So that means that we're going to multiply it by 4. And this is going to be respirations per minute. Okay? So we are going to not ask the patient to breathe because we don't want to make them aware, but we're going to count 1 inhalation and 1 exhalation to say that there's 1 respiration. So every time that we see the patient doing, that's 1, okay? I recommend for you to go and start taking the pulse. When you finish taking the pulse, just keep your hand in there, look into the patient, and you can look the movement. You don't have to tell them I'm counting. You just have to look at the patient. Patient is going to think that you're still taking the pulse, and you're going to see the movement in the chest area. Every time that elevate and decrease, that's 1, 2, 3, 4. I count 4 in 15 seconds. So I'm using the technique of the 15 seconds. So it's 4 respirations times 4, that is 16 respirations per minute, okay? And the normal of the respirations go from 12 to 20. So this patient is breathing normally, okay? What other technique you can use if you feel like you're not able to see the movements on the chest of the patient, you can put your hand on the shoulder of the patient. Oh, I'm taking your pulsar. One hand is in the hand, taking the pulse. The other hand is in the shoulder, and you can feel the movement on the shoulder, okay? And that is going to give. And the last thing that you can use is listening. Some patients have heavy breathing, okay? So you don't need to observe, you don't need to put your hand, just hear. And patients are gonna be like, and you can hear when they inhale and exhale, inhale and exhale. Now, if the patient is sick, for example, an asthmatic patient, you can hear that they're trying to grasp from air. Okay, so you can listen to patients too. So every time that you hear an inhalation and exhalation, that's one respiration, and then you just one technique to put it on. The respirations also change with the age. From 0 to 1, the breathing per minute go from 26 to 40. From 1 year to 6, the respirations go from 20 to 30. From 6 to 11 goes from 18 to 24. From 11 to 16 goes from 16 to 24. Adults and elderly go from 12 to 20. And in the elderly patients, we can give as a normal as 24 per minute. Also in the respirations, we have to look the rhythm, okay? It's not just counting. We have to look how deep they do it, if they have any trouble, if they look really in distress to do it, or it's just so easy and normal that they seem like they're not doing anything, okay? With that, we're gonna start talking about abnormalities in the respiration. The abnormalities in the pulse, we say bradycardia, tachycardia, irregular or regular. In the breathing, we're going to identify types of respiration. For respiration, we are going to use NEA. This means respiration. Okay? So when we talk about alterations in the rate, we're going to talk about tachy. Tachy means up. NEA means respiration. So we are talking that the respiration is quick and shallow, okay? Okay? We're making the movement. They are breathing really quick. Brady means low. NEA means respiration. So this is abnormal, slow breathing, okay? The patient is like, it's really slow. And we say that the normal is from 12 to 20, okay? So tachy is going to be about 20. Brady is going to be about 12. Apnea. A in medicine means nothing, no, or none. Okay? It's not there. Apnea means respiration. So apnea means the cessation of the breathing, but it's a temporary. There's no respiration for a period of time. Respiration arrest is going to be the cessation of the breathing that is abruptly and is permanent. For example, a patient on cardiac arrest, the heart stops beating, so the rest of the body stop working. So there's no respiration either. There's an abrupt stop in the breathing. Patient is not breathing and doesn't have a heart rate. Hyper means also up, okay? NEA is going to be respiration. In the difference between tachypnea and the hyperpnea is that tachy is just quick and shallow, and the hyperpnea is a respiration that is more elaborated. It's increased, it's rapid, but the patient has elaborated more. So tachypnea is going to be quick and shallow, okay? I run to the parking lot because I forget my phone, and then I came back and run upstairs in the to the second floor. I'm tired. Man, I'm tired. Quick and shallow, tachypnea. But hyperpnea is going to be quick, depth, and elaborated. So I'm going to be like, I'm feeling a lot of difficulty doing it, but I'm going to try to do it quick because I feel like it's not enough oxygen coming inside. Because the breathing is managed by the nervous system. Any affectation of this nervous system can give patterns in the respiration. And the most common ones is going to be the pattern of China stocks, when in here, there's going to be an alternating period between apnea and tachypnea. Tachy means up and shallow, and apnea means cessation, and it's temporary. So we're going to see a patient it's temporary. Alternate between tachy, pause, tachy. The Kuznel breathing is a type of breathing where it's going to be a deep breath, forced breath, and is usually associated to metabolic acidosis. It's always going to be kind of quick, but you're going to see that the patient is forcing themselves, like, okay? It's quick, deep, and it's forced. And if you have a patient that, if you can lift the shirt, you're going to see the muscles in the rib cage area being going inside and outside. They're forcing to make sure that the thoracic box expand enough. The bio breathing is a rapid, shallow, and irregular breathing. And in here, there's going to be periods of apnea that is going to be more prolonged, okay? And this can be because of any intracranial pressure. So the bio breathing is we're going to see it in patients that has been in an accident, for example, a car accident, they hit the head, or the kids that they fell and they hit the head and they have a intracranial pressure going on. Okay, so there's going to be rapid, shallow, irregular, and prolonged apnea. Okay. Now we're going to talk about temperature. The body temperature is the magnitude of the heat or cold that is managing the body human. The hypothalamus in the brain is the organ that is going to be responsible to regulate this, okay? Hypothalamus is the organ that is responsible to regulate the temperature. In a healthy adult patient, the normal temperature is going to be between 97.8 to 100.4, okay? And also we're going to take in account where are we taking the temperature in this patient. If you're here in Texas, outside, normal temperature can be 102, 104 degrees. So if you're taking the blood pressure, the temperature in the forehead from a patient that is coming from outside, that's something that is going to affect the real temperature on the patient. Okay, so we have to take into account where are we taking the temperature. For the temperature, we're going to identify states, and this state is going to be related to the normal temperature or to the increase or decrease of the temperature. When we talk about normal temperature, remember what means the A in medicine? Means nothing, no, or nothing or none. So normal body temperature is also going to be known as a afebrile state. A nothing or none. Febrile is fever. So without fever, no fever, that's normal. We normally don't have fever, don't have elevation of the temperature. And our second state then is going to be the febrile state. In the febrile state, we are going to identify elevation of the normal temperature, means above 100.4. In here, we're going to identify two different types. Number one is the fever. Fever is going to be a sign of any inflammation or any infection in the body. This is the sign of the body that he's trying to fight something that is not supposed to be in there. So anything about 100.4 becomes febrile state, and it's a fever. But then we're going to have a hyperpyrexia. The hyperpyrexia is that extremely high temperatures, something above 105 degrees, okay? So if you have a patient coming to your clinic and you take the temperature and it's 106 Fahrenheit in temperature, this patient is febrile, but he is on hyperpyrexia, okay? And this means that this patient can be in a shock for any sepsis, states that require extremely high temperatures. But also hyperpyrexia can be seen affected by the environment. Like I said before, we're in Texas. Outside, sometimes it's normal for us to be in 104, 105 degrees. If you have been outside and you have been walking and then you come inside and take your temperature, probably your temperature, if you take it in your forehead, is going to be 106. It doesn't mean that you're in hyperpyrexia because you're sick. It means that you're in hyperpyrexia because it's affected by the environment. The body temperature, we can take it in different places. We can take it in the ear, and it's that otic temperature. The ear is an otic temperature. In the mouth, when we put the thermometer in the mouth, this is oral temperature. When we put the thermometer under the arm, this is the axillary temperature, because we put it under the arm in the axilla. Temporal artery or frontal temperature. Because we're going to use either our temporal side right here, or we're going to put it and place it to the forehead. This is what we learned in COVID, right? Everybody was taking the temperature in the forehead. And then we're going to have the rectal. Like the word say, we're going to use the rectum. So we're going to place a thermometer inside of the rectum. From all these areas that we can take the temperature, rectal is the best way to take the temperature because it's inside of the body. The second best place to take the temperature is the otic area because it's also inside. So it's really hard for you to tell, hey, sir, can you please put your pants down? I'm going to take your rectal temperature. Nobody's going to let you do that. So rectal is most used in kids. Otic and frontal is most used in adults. Some of clinics, you might see some glass thermometers, and it's usually not used anymore. But these glass thermometers are full of mercury. And what we look is the raising or the movement of that mercury going up in the pipette or the thermometer. If you are going to take a rectal temperature, you are going to insert the thermometer 1.5 inches in the adult and 1 inch in the children. In the infants, less than 1 year old, 0.5 inches, okay? This is the most accurate place for the body temperature. In the ear canal, you're going to use a thermometer like this one, okay? For this, you have to use a protection. It's a sleeve that is going to be put it in the thermometer, okay? You will see that there's a on button and the button to take the temperature, okay? So you open the thermometer, you place it on the sleeve, make pressure, there's a sound, and the sleeve is going to be inside. Turn on the thermometer, okay? And you're going to place it inside the ear canal, okay? Once that is in the insert, press it again. Well, right now it's going to say low because we don't have it in the ear canal. But when this is done, then we are going to press. And that is going to take that sleeve out. We do not touch the ear, the sleeve. This is going to go directly to the trash and we push it, okay? If we do it on the skin, then we're going to use this kind of thermometer. You don't have to put it close to the forehead. You don't have to put it like tap it in there. You just have to be a few millimeters or 1 or 2 centimeters from the forehead so it can be taking the temperature. This is the different kinds of thermometers that you will see. This is the kind that we were using right now. This is oral. Rectals usually are going to be glass, okay? And these are the ones that we use for the temporal or the frontal thermometer. Depends on the place that you're taking, it might change, or the range of normal temperature might change. In oral for adults, it's going to be 97 to 99 degrees because this can be affected. If I'm drinking coffee, probably my mouth is going to be a little bit hot. If I was drinking water or any cold fluid, that's going to modify the temperature of my mouth. In the children's, also going to go from 97 to 100 normal. Rectal, 97.8 to 100.4. This, like we say, is the preferred method for kids. It is the most accurate one. The axillary is going to be from 97.8 to 99. Tympanic is going to go from 96.4 to 100.4. You see how it drops in here, right? But it's accurate because it's in the inside of the body and it's not modified by any environmental situation. And then in the temporal or the frontal, we go from 97.8 to 100.4. That's what we are using these as reference for normality, because now we are mostly using the ones for the front or for the temporal area. The abnormalities that we can see in the temperature when we have a patient with fever is evaluate the presentation of that fever. And that is going to give us the different types or patterns in the type of fever. The first one is the continuous fever. This is a sustained, continuous fever. What is saying that patient is always going to be above 100.4, but there can be a variation of 1 degree or 1.5 degrees Fahrenheit. And this is in a period of 24 hours. So the patient is always going to be febrile, but never is going to go back to normal. So let's say that the patient has been on 102.5 and then drops to 101 and then drops back, comes back again to 102, 102 comes down to 101 and then goes back up to 102.5. So it never drops to normal, but there's a change of 1.5 degrees Fahrenheit. When we have this, there's a continuous infection, okay? Remittent fever is the temperature that is going to stay above the normal, meaning above 100.5, always a fever, but there's going to be a change in 3 degrees Fahrenheit, never coming back to normal, always on fever, but the change or the jumping is going to be 3 degrees Fahrenheit. Even 2 degrees Fahrenheit, that's going to be considered remittent. Intermittent fever is what we know as a comes and goes. This fever is going to present periods of elevation of temperature above 100.4, but then there's going to come periods of coming back to normal, in the highest normal, okay? That is the comes and goes or intermittent. Relapsing fever is the presentation of high elevation or high temperature fever, but the patient is gonna come back to normal and being in the normal range for several hours, and then again present another set of fever for several hours. Okay, let's see this example. You're about to take the temperature of a 6-month infant, and he being seen at the pediatrics office for vomiting and diarrhea. Which route will you use and why? What special considerations you will need to keep in mind in this specific situation, okay? Number 1, the patient have vomiting and diarrhea. So we cannot place anything oral in the mouth because we're gonna make him feel nauseated again and probably vomit again. The patient is having diarrhea, so we are not going to put in the rectal area because patient have diarrhea. It can be contagious. You always have to look for your safety. And of course, we don't know if the patient is going to have a bowel movement, okay? It's a key. The other thing that we're going to look is, let's look for a better way. The second best place to take the temperature is going to be tympanic, okay? So we can use tympanic to take the temperature, or we can use the temporal, okay? The size in the head or the front, because it's a 6 months baby, okay? Because the patient has been having vomiting and diarrhea, we're always going to think that this is something infectious. So we have to protect ourselves, and let's put gloves because we're gonna touch this patient. Standard precautions, okay? So now we're gonna talk about the anthropometric measurements. And when we bring the patient to our room and we start doing our physical exam, we're going to include this even if it's not part of the vital signs, but we're going to do it at the same time, okay? So the anthropometric measurements is going to include the height, the weight, and in the infants and kids, the head circumference, okay? In here, we are going to either use kilograms or pounds. That depends of the preference on your clinic, okay? Based on the relation between the height and the weight, you are going to get the body mass index, BMI. In the infants, we also going to weigh the patient, and we are also going to measure them. That's the length. These measurements always have to verify every single visit. Most of the patients on the adult, the first time we get the height and the weight, and then in the subsequent visits, we're just going to be taking the weight, okay? Because nobody's going to grow too much. Nobody is going to shrink too much in a certain period of time when you're in an adult. But in a kid, this is something that we're going to measure in every single visit, because the height and the length of the patient or the circumference is letting us know how the growth is in this little patient, how they are development. Are they falling back in the chart? Are they growing too slow? Is there something going on with the growth chart for the patient? Or the patient is getting too big? Is it getting too heavy? That's what we're doing in the kids every time, okay? In the adults, the height can be done every year, just to make sure that there's no difference, okay? For the children, there's a special scales, okay? We can use the adult scales on kids that looks too big or that they are able to stand and stand still. We can use the adult scale if the patient doesn't need to be carried or that they are just needing somebody next to them. In the infants, the infant scale, there's going to allow the patient to be laid in the scale and give us an accurate weight. There's always going to be a wall chart for the kids, for the children, and it's going to make sure that the growth is accurate to that scale. We're going to see about that growth scale when we get to the systems and we start studying pediatrics, okay? The circumference of the head in the infants, we are going to use a tape measure, okay? We're gonna place it around the head of the kid and we're gonna put it in the back, going all the way onto the top in the forehead, okay? We have to do this in every single visit. Other kind of measurements that you might do, and this is depends on what kind of clinic you work to, is the diameter of a limbs. For example, the size of the arm or the legs. You have to make sure, like for example, if you work in a wound care office, they're probably going to ask you to measure wounds or to measure any injury to make sure that it's growing or it's getting better. Chest circumference in the infants, they're going to ask you to measure the chest, and this is if there's any discrepancy between the abdomen cavity and the thoracic cavity. So the relationship between the weight and the height is the body mass index, is that ratio in between these two measurements. To obtain the body mass index, we're going to use formulas that is going to allow us to know. And this is just used to give a category of being in a normal weight, being obese, or being underweight. You're going to see three different formulas. The most used one is going to be the one that we use, the weight in kilograms divided by the height multiplied by 2 or multiplied twice. That's the BMI. So for example, a patient that weighs 70 kilograms and measure 1.63 meters, the formula says 70 kilos divided by the height twice. So it's 1.63 multiplied by 1.63. 70 kilograms divided by, we're going to do 163 by 1.63. That is 2.65. And this is equal to 70 divided by 2.65. It's 26.4. This is the answer. The BMI of the patient is 26.4. I'm gonna put it here, 26.4. So once that we obtain the number of the BMI, we're gonna come to this chart and we're going to look where the patient is. Underweight, the normal is going to be from 8.5 to 24.9. Underweight is going to be anything under 18.5. About 24.5, then we're going to start classifying the patient. Overweight, go from 25 to 29.9. Above 29.9, we have obesity. Obesity is from 30 to 34.9. Severe obesity is above 35 to 39.5. Morbid obesity, it's 40 to 49.9. And extreme obesity is anything above 50. So this patient was 26.4. Based on this chart, the patient is overweight. Patient is overweight because the patient was 26.4 and the range is in here, okay? So make sure that you learn the formulas to get BMI, okay? When you're measuring the height of the patient or the person, it's important that you are in the level of the scale that is measuring that height, okay? You're not have to be on the side. You cannot be above or under. You have to be in the same level so you can see the exact number. The patient has to be without shoes, barefoot. He has to step close to the wall or whatever is the scale, and they have to be with the chin in a level of the shoulders, not like this or not like this, okay? And the feet has to be close to the wall, not in the toes, okay? Okay, the medical assistant is about to weigh a 6-month infant using the infant scale. When the medical assistant placed the infant on the scale, she noticed that the diaper is very soiled. What should the medical assistant do? Having a baby, they have a lot of clothes, or they pee a lot, or probably there's dirty diapers. So we have to make sure that that diaper is dry. So we're gonna ask mom or dad to change the patient before using the scale. A 26-year-old athlete visits the medical office for a routine checkup. The medical assistant takes vital signs: temperature, pulse, respiration, and obtain the following. Temperature is 98.8, pulse is 52, and respiration is 18 per minute. What the medical assistant should be doing about this? Remember, we're going to see the patient as a whole. Is an athlete, is a young person, and is just coming for a regular or routine checkup. So this patient is not sick. It's not complaining about anything. It's an athlete, so that means that it's fit. They probably have a lot of resistance, and it's a young person. So the temperature, it's normal. It's 98.8. The pulse is 52. The normal heart rate is from 60 to 100 beats per minute. Anything less than 100 is bradycardia. Anything above 100 is tachycardia. So if the patient is on 52, this means that the patient is below and the patient is bradycardic, okay? What we need to do, we already saw that the patient is okay, that he is a young person and that he is an athlete. So I'm just gonna go and compare the previous vital signs results to make sure that this is something normal on him, okay? We are going to report as a low blood pressure, as a low heart rate to the doctor or the physician, whoever is going to evaluate the patient, but we know that this probably is going to be for his normal limits, okay? Because we're going to compare with the prior ones. So with this example, I want to make sure that you understand that we have limits of normalities, but we also have to relate the numbers that we obtain when we take the vital signs with how we are seeing the patient. The patient is individual, and not everybody is going to be normal as 120/80 on blood pressure. Normality can be 110/70 for some people, okay? So it's a range, and we have to evaluate the patient as a person, individual. A 67-year-old patient in the medical office is complaining of headaches, okay? Has pain, headaches. The blood pressure is reading 212/142, okay? What should do the medical assistant about this patient? Number one, blood pressure 202/142. If you remember the American Heart Association, it said that this is a hypertensive crisis. So the first step is give 2 or 3 minutes, retake the blood pressure, and confirm that this is the blood pressure. And the second one, we are going to make this patient priority, and we're going to report it to the doctor because this patient probably needs to go to the ER. Why? Because the blood pressure is high and the patient have symptoms, which is the headache, okay? Blood pressure is a high, the high blood pressure and headaches is a high risk for any stroke. So the patient is already having that headache that can be a sign of a stroke going on. Make sure that you have all the materials in the place where you're going to take the vital signs. Depending on where you work, the setting to take the blood pressure or the vital signs can change. There's some clinics where they have a specific area where you triage the patient, take the blood pressure, do the interview, and then you take the patient to the room where the doctor will see. There's another settings in clinics where you walk the patient from the lobby, you measure, you take the height and the weight, and then you walk the patient to the room and you take the vital signs in the room and finish with the interview. So depends on how your setting is. Just make sure that you have all the instruments that you will need for take the vital signs. Blood pressure, a sphygmomanometer, stethoscope, temperature, thermometer, and pulse ox. So you can make sure that you take that pulse ox, okay? Inform the patient of what you're going to be done, what you're going to be doing. I'm going to place the cuff in your arm, sir. I'm sorry, my hands are cold, and this might be cold, okay? You have to know the patient that you're going to touch and put it. I'm gonna take your temperature, sir. I'm going to point this to your forehead or to the side of your head, okay? I don't know if you remember, there's some people that still think that that is going to erase the memory or is going to do something. So let's make sure that the patient feels comfortable what they're doing. You're gonna take the temperature in the ear. Sir, I'm going to pull a little bit your ear and retract and get this thermometer inside of your ear. Let them know what you're doing, okay? Anything that needs to be discarded, please make sure that you discard it correctly. If it's something that has been in touch with any body fluid, make sure that you take it in a biohazard. If not, everything else can be in the trash can. Wash your hands before and after each patient, okay? Or use alcohol sanitizer. Make sure that you record the procedures. Make sure that you enter those vital signs in the patient chart. So it can be there for the doctor to review. Okay, so let's go practice. Make sure that you can identify the radial artery to take the heart rate, Make sure that you can identify the brachial artery to take the blood pressure. Make sure that you are listening correctly and you are positioning the stethoscope in the right position, the earpieces, so you can hear better. The more that you practice, the better that you will educate your ears so you can identify all the cortical sounds. Please come back to us if you have any question, and I'll see you next class. Thank you.